So, good afternoon to all, and welcome to this webinar about head and neck sarcoma. I'm Gilles Dolivet, I'm a head and neck surgeon, and me and my colleagues will try to explain you the principle of treatment of those difficult to treat tumors. First, just a presentation of the European Society of Surgical Oncology. It's an old society. I'm a member for about 30 years now, and this society is dedicated to surgery of tumors, teaching, technical development, and recognition of surgical oncology as a specialty. And we have every year a congress. There are many reasons for oncology surgeons to join the ESSO: the knowledge, the advantage of publication, the grants, the educational grants and exchange between surgeons, the research opportunities of all the community, and the global network, about 4,500 members of these communities. Today we are talking of education in the concept of the Education and Training Committee, and specifically is sarcoma community. We have also the European Journal of Surgical Oncology, where you can publish your research, article, editorials. And next, we have also a very interesting board of surgery qualification in cooperation with the European Union of Medical Specialists. And every year we have an exam where you can get the title of Fellow or the European Board of Surgery. The exam is usually in English, but also in German, in Spanish, and we had one in French 4 years ago in Bordeaux. We have workshops, webinars, and next, please, courses, virtual courses, and also, and last but not least, the Congress. The next one will be placed in Madrid in November 2026, and I hope to see many people in this Congress where we can share about this year innovation and challenge worldwide. So coming to our webinar today, we are going to talk of principle of treatment, radiology, imaging, surgery of resection, and reconstruction with my colleague. Next, please. I will show quickly 4 cases illustrating the complexity of management. Next. Next, please. First case that happen often, the cases of patients with sarcoma in hereditary area. As you can see, the example here, and we had very big difficulties to have the diagnosis and treat by surgery. Please, next. And as you can see, a very big surgery with a reconstruction, and 3 months after relapse, and 3 months after relapse, exitus. So all the cases are not so sad. Next, please. You can see the example of a young patient with a big tumor of the maxilla. After biopsy, it was supposed to be a spinal cell rhabdomyosarcoma. He had hemimaxillectomy and reconstruction, and with the diagnostic of, in fact, poorly differentiated myofibroblastic sarcoma. And it was considered with fragmented resection and HER2 margins. Next, please. And in fact, 10 years after, he is still here and no evidence of disease. So, can explain. Who can explain? Next, please. This is another case of a patient with laryngeal symptoma and strange images of the larynx. In fact, it was chondrosarcoma of the arytenoid cartilage, and he had a cervical resection, extramucosal resection. And next, please. 2 years after, he's still here. No evidence of relapse and good function of the larynx. And the final case is just operated 2 months ago with a big sarcoma, a rhabdomyosarcoma of the tongue. Next, please. No, next. Thank you. And as you can see, a very large resection and very good margins, and that we hope it will be functional and curative. Next. So that's why we organize this webinar about management on head and neck sarcoma, because there is a need for thorough understanding of these entities and of their management, and to understand the complexity of the location in head and neck area. It's very essential to be familiar with the therapeutic sequences, and it's essential to know that some head and neck surgeons have specific skill also for resection and also for reconstruction. And we are going now to let my colleague speaks, and I think that it will be supposed to be Yolanda Fernandez, which you can ask question with the button question and answers. And if during the webinar, we will be able to answer your question. So we can go to the next presentation, please. Yolanda Fernandez is a medical oncologist specialized in head and neck, and she accepted to talk in this webinar.
Sorry, Yolanda, you're muted. Can you unmute?
Excuse me?
Can you hear me?
Yeah.
Do you see my screen?
Yes, it's not full screen.
Attends. Hop. Okay. Donc, good morning, everybody. Thank you for the kind invitation.
We don't see the full screen, and we see your notes.
The screening?
No, it's not full screen.
Oh, yeah, if you can see the button at the end in the right corner, there's a button. You can click it there. Right before the bar, right before the minus plus bar, you see the full screen button. Can you click on the button?
Button.
Yes.
Entire screen. Share. It's not okay. Web. Tick. Is it okay?
Yeah, you need to select the PowerPoint first. Okay. Now can you click? There you go. And then you can see at the bottom. Okay, perfect. Now we see your full screen.
Is it okay?
Yeah.
Okay.
Thank you.
Thank you.
Non.
No?
Non, parce que là, on est en mode présentation.
Yeah. Okay.
Il faut cliquer sur partager en bas.
Yeah,
You
we
need
can
to
see
press
both.
partager.
Voilà.
Okay, now it's good.
I need to see my notes. I don't know if I can see my notes for the presentation. Sinon, Tao, est-ce que tu... Ouais.
Yeah, sure.
Vous pouvez mettre... Est-ce que tu peux nous aider? May I ask your help, Tao?
Yeah, sure. I can share the screen.
Okay.
And then you can use your speaker note. Okay, I will
Thank you.
replace your share. No worries. I will open my share. Sorry, everybody for keeping you waiting. It should move forward now.
It's the last PDF.
Yeah.
Type. Okay. Donc, let's start. I'm a medical oncologist. I work at the Institut de Cancérologie de Lorraine in France. In this presentation, I will discuss the management of head and neck sarcomas with a particular focus on their epidemiology and diagnostic approach, on treatment principles. This is my slide of disclosure. Donc, next presentation outline. I will structure this presentation into 6 main parts. Little introduction, pathology and molecular updates, diagnosis, treatment strategy, prognosis and outcomes, and emerging therapies and research priorities. Head and neck sarcomas represent a rare and heterogeneous group of malignant tumors of mesenchymal origin, accounting for less than 1% of all head and neck malignancies. What makes them particularly challenging is not only their rarity, but also the remarkable histological diversity. More than 50 distinct subtypes are described. This heterogeneity has implication for clinical practice as it requires specialized pathological expertise and a multidisciplinary approach. Let's go to epidemiology. Head and neck sarcomas are exceptionally rare, with an incidence of less than 1 per million annually, which limits large-scale evidence and make management challenging. Long-term shared data highlights their rarity, with relative few cases reported over several decades. Epidemiologically, there are distinct age-related patterns. Adults show a male predominance, with tumors primarily involving the skin, soft tissues, and craniofacial skeleton, and histologies predominant are malignant fibrosis, histiocytoma, and vascular sarcomas. Pediatric cases demonstrate a slight female predominance, with rhabdomyosarcoma being the dominant subtype, on parameningeal region, including the nasal cavity and paranasal sinuses. From an anatomical standpoint, distribution varies across the neck, scalp, sinonasal tract, and oral cavity, each associated with distinct sarcoma subtypes. Overall, the key point is the marked heterogeneity and the clear difference between adult and pediatric disease, which are critical for guiding diagnosis and treatment. At the London Sarcoma Services, 245 patients with head and neck sarcoma had surgical treatment between 2007 and 2019. The commonest subtypes of soft tissue sarcoma were rhabdomyosarcoma, pleomorphic sarcoma, malignant peripheral nerve sheath tumor, and leiomyosarcoma. Vast majority were extragnatic, a large proportion were high grade. The commonest types of head and neck bone sarcomas were osteosarcoma, chondrosarcoma, and Ewing sarcoma. these subtypes have a higher predilection for the mandible than the maxilla. Extragnatic presentations account for 11%. Mostly are high grade. Let's go to risk factors. Several etiological factors have been associated with sarcoma development. Prior exposure to radiotherapy remains one of the most clearly established risk factors. In addition, hereditary cancer predisposition syndromes and environmental exposure, arsenic and vinyl chloride, and chronic lymphedema. Histologic classification by the World Health Organization provides a structured framework for sarcoma categorization based on histological and molecular characteristics. Accurate classification is critical as it directly informs prognosis and therapeutic decision-making. Increasingly, classification relies not only on morphology and immunohistochemistry, but also on molecular alterations. Molecular characterization has become central to modern sarcoma diagnosis. At the genomic level, some sarcomas exhibit specific alterations, such as gene amplifications, while others display complex genomic instability. At the transcriptomic level, recurrence gene fusions are particularly important. As such, molecular profiling is now an integral component of accurate diagnosis and in some cases may guide therapeutic strategies. From a clinical point of view, clinically patients most often present with a painless, progressive, enlarging mass. Additional symptoms depend largely on the anatomical site. May include obstruction, dysphagia, or nerve dysfunction. Because these features are often non-specific, early diagnosis may be challenging. This slide outlines the clinical behavior of head and neck sarcomas, particularly patterns of spread. Lymph node metastasis is relatively uncommon, occurring in fewer than 14% of cases. However, this varies with histology. Rhabdomyosarcoma, clear cell sarcoma, angiosarcoma, and Ewing sarcoma have a higher propensity for nodal involvement. This is very important for risk stratification. The benefit of prophylactic neck dissection in high-risk patients remain controversial. Although rare bone sarcomas can also present with regional lymph node disease, and this typically indicates a more aggressive course and poorer prognosis. Most patients present with localized disease and distant metastasis is seen in less than 10% of cases, commonly the lungs. So, while nodal and distant spread are relatively infrequent, their presence significantly impacts prognosis and management decisions. The diagnostic workup relies on multimodal imaging. MRI is generally preferred for evaluating soft tissue extension, where CT is useful for assessing bone involvement. PET-CT may contribute to staging in selected cases. However, imaging must always be completed by histological confirmation. Accurate histological diagnosis is critical in head and neck sarcomas, and it directly determines treatment strategy and prognosis. The process begins with a well-planned biopsy, aiming to obtain adequate tissue while minimizing morbidity and preserving future surgical options. Both open biopsy and core needle biopsy are valid approaches. Core needle biopsy is increasingly favored as it provides reliable information on tumor architecture, grading, and molecular features with a very low risk of tumor seeding reported at less than 1% and without clinical significance. Modern diagnosis goes beyond morphology and relies heavily on molecular characterization, particularly through techniques such as FISH. Specific genetic alterations have been already noted and are highly informative. These markers are essential for accurate classification and risk stratification. Ultimately, this highlights the importance of a multidisciplinary approach with close collaboration between surgeons, oncologists, and pathologists to ensure optimal diagnosis and management. Staging integrates tumor size, histological grade, and metastasis status. Several classification systems are used in clinical practice, including AGCC, TNM, and sarcoma-specific grading systems. These parameters collectively inform prognosis and guide treatment strategy. In terms of management principles, management of head and neck sarcomas requires a truly multidisciplinary approach. Treatment planning should involve specialized teams, including surgeons, oncologists, radiologists, and pathologists. A referral to dedicated sarcoma center is strongly recommended whenever possible. The cornerstone of treatment remains wide surgical resection, often difficult due to critical anatomical structures, combined with radiotherapy. Primary curative modalities if resectable. Reconstruction preserves function and appearance in this anatomical region. Therapeutic decisions must carefully balance oncology control with preservation of function. Speech, swallowing, and aesthetic outcomes are critical considerations with significant implication for quality of life. Radiotherapy plays an important role in local control. Advances such as intensity modulated radiotherapy and proton therapy have improved dose precision and reduced toxicity. These techniques are particularly valuable in the head and neck region. Treatment strategies vary according to tumor grade and subtype. For soft tissue sarcoma, surgery remains the cornerstone when feasible. The surgical principles are similar to those used in head and neck bone sarcomas, and compartmental resection is recommended to prevent local recurrence. Low-grade disease is treated primarily with surgery. Adjuvant radiotherapy is commonly indicated in high-risk situations. Chemotherapy is reserved for selected cases, particularly in high-grade or chemosensitive tumors. Neoadjuvant chemotherapy may be used depending on histological grade, with a focus on high and intermediate grade tumors. On the number of cycles and the duration of treatment are modulated by the extent of the disease and the response, with interim assessment with PET, CT, and MRI. The role of adjuvant chemotherapy for most of these tumors, however, remains unproven, but is considered in cases that are high risk and chemosensitive, or when local relapse cannot be surgically salvaged. This randomized phase 3 study show no benefit of histotype-tailored neoadjuvant chemotherapy over standard anthracycline ifosfamide-based treatment in high-risk soft tissue sarcomas. On the contrary, the standard regimen demonstrated superior efficacy, reinforcing its role as the current standard of care. These findings suggest that despite Despite advance in sarcoma biology, histology-driven chemotherapy strategies have not yet translated into improved clinical outcomes and should be interpreted with caution. Standard chemotherapy, therefore, remains the cornerstone of treatment of this patient population. This table compares the two main approaches to treating one of the most common soft tissue sarcomas, rhabdomyosarcoma. In the US, the COG use a highly standardized, high risk-based strategy with treatment intensity guided by the staging and surgical findings and relatively fixed chemotherapy protocols like VIC. In contrast, the European ESSO takes a more adaptive approach, adjusting treatment based on response and aiming to reduce long-term toxicity, often used delayed surgery and ifosfamide-based regimes. Given the rarity of these tumors, participation in clinical trials is strongly encouraged. This is essential to improve the evidence-based and optimize patient outcome. This is an example of the clinical practice guidelines for patients with rhabdomyosarcoma. Its management differs significantly from other sarcomas. It typically relies on multimodal therapy, combining chemotherapy, radiotherapy, and when appropriate, surgery. On treatment strategies are highly dependent on tumor location and risk group. Concerning the strategy for bone sarcomas, head and neck osteosarcomas are extremely rare, accounting for less than 1% of head and neck cancers and most commonly arise in the mandible and maxilla. Because of this rarity, high-level evidence is limited, and treatment strategies are often extrapolated from long bone osteosarcomas, although these tumors behave differently. Management depends largely on histological grade. Low-grade osteosarcomas are typically resistant to chemotherapy and are best managed with complete surgical resection alone. Achieving clear margins is critical, and incomplete resections increases risk of local recurrence and dedifferentiation, which significantly worsens prognosis. In contrast, high-grade osteosarcomas are more aggressive. They show lower responsiveness to chemotherapy, and failures are more often local than distant. Importantly, current evidence does not demonstrate a clear survival benefit from neoadjuvant chemotherapy on head and neck osteosarcoma, even in higher grade disease. For advanced or recurrent cases, prognosis remain poor with less than 20% long-term survival. Although emerging targeted therapies as multi-kinase inhibitors some promise. The new developed oral small molecule receptor tyrosine kinase inhibitor anlotinib and the fibroblast growth factor receptors inhibits targets VEGFR. Targeted therapies, including tyrosine kinase inhibitors, have shown promising activity in advanced sarcoma. They represent an important option after failure of conventional chemotherapy. These studies are systematic review and meta-analysis evaluating the efficacy and safety of amlotinib in advanced bone and soft tissue sarcomas. The analysis showed that amlotinib provides meaningful disease control, improvement in progression-free survival, and a measurable objective response rate, particularly in heavily pretreated patients. In terms of safety, Generally, amlotinib is well tolerated. Overall, the study supports amlotinib as a promising therapeutic option in advanced sarcomas, especially in patients with limited treatment alternatives. This phase 2 CABON trial evaluated the activity of cabozantinib in patients with advanced Ewing sarcoma and osteosarcoma. The study demonstrated meaningful anti-tumor activity, with a majority of patients achieving disease control and progression-free survival benefit. Overall, this study supports cabozantinib as a promising treatment option in advanced bone sarcomas, especially in the relapse or refractory setting. The role of immunotherapy is unclear. There is an enormous pipeline in course. In terms of prognosis factors, tumor size, height, weight, positive margins, and subtypes are independent predictors, but molecular profiling may improve risk stratification. In terms of follow-up, this study investigates the role of tumor-informed circulating tumor DNA, or ctDNA, in osteosarcoma. ctDNA was able to detect minimal residual disease after treatment and, importantly, predict relapse earlier than conventional imaging. Patients with detectable ctDNA after therapy has a significant higher risk of recurrence, while those without ctDNA detectable had better outcomes. This suggests that ctDNA could serve as a powerful biomarker for real-time disease monitoring, helping to identify patients at high risk of relapse. Overall, this approach represents a step toward for more personalized management, allowing earlier intervention and better risk stratification in osteosarcoma. Future efforts should focus on biomarker development, broader clinical trial inclusion, and international collaboration to identify predicted biomarkers, expand clinical trial inclusion, and promote international registry data sharing and biobanking. In summary, some take-home points. Early suspicion and referral are critical. Biopsy should precede treatment. Management must be multidisciplinary, and a specialized center play a key role. Thank you very much for your attention. I will be pleased to take any question.
Thank you very much, Yolanda, for this very complete presentation. Until now, we just have one question, and it is about acceptable surgical margins. So we will answer to the question with the surgical presentation. And because time is running, I think that now we can go to the presentation of Dr. Philippe Enrault, my colleague, and which is a very specialized radiologist in head and neck.
Thank you, Dr. D'Olivet. Is everyone seeing my presentation?
Yes.
Yes, perfect.
It's not full screen.
Full screen. Here. That's okay.
Perfect. Thank you very much.
So, a little bit of, yes, that's good. So, imaging of sarcoma is a challenge, as previously said, because it's an heterogeneous pool of tumor. It's rare. It's not always clinically suspicious. And this activity has an emotional burden because of young patients and sometimes high severity of the case. Biopsy could be of difficult access. and the disponibility of specialists in referral centers could be quite limited. So what to expect from a radiologist? Radiologist has to detect imaging criteria for suspicious for suspicion of sarcoma. We wrote the trap of premature pathological conclusions in the imaging reports. He has to precise the local staging because the T is one of the most prognostic factor with an impact of local control after surgery. He has to describe the lymph node involvement, given that it's very rare, with some exceptions previously reported, in example in synovial sarcoma or rhabdomyosarcoma in adults. He has to specify distant metastasis, and it's more common in sarcoma, especially in the lung. And he has to highlight, and it's the most important point at this time, he has to highlight the need to refer the patient to a specialized care pathway. So which imaging modality is the best? As you know, it's MRI in the soft tissue. So it's theoretically the optimal modality because of lesion contrast, the precise analysis of critical interfaces to show orbits, meninges, brain bone extensions, perineural space, even if rare. However, in some countries like France, the number of MRI units are still insufficient. And one oncological head and neck MRI appointment slots last at least 30 minutes. So it can be a limitation to the access of MRI without delay the workup. MRI could be inconclusive in case of motion artifacts. If the patient moves, all is lost. Metal artifacts with bubble-like black bubble with good masquerading lesion. And the problem with MR is that hair, cortical bone, and calcified cartilage share the same black signal. So what makes a good MRI protocol? You need to have axial sequences, especially T1 weighted, to see fat, blood, and precise anatomy. T2 weighted to recognize fluid versus solid and detect lymph nodes. And diffusion weighted imaging to identify lymph nodes and ball involvement. One point important is to have coronal T2 weighted sequences because it's frequently the key sequence. These coronal T2 sequences can provide critical information about anatomical interfaces on the skull bars or orbits, can depict bone involvement, the normality of cerebrospinal fluid, cortex, the fat planes. It can distinguish between sinus retentions and tumor. And at least the gadolinium injection sequences to distinguish between tumor versus normal tissue in ideally 2 or 3 planes. So we have to not to forget that CT is still mandatory in the workup. Head and neck and chest CT are ideally performed at referral centers with intravenous contrast. We have to notice that a dedicated sinus CT is mostly insufficient. You have to see also the soft tissue with contrast. The CT must cover the T plus N plus M areas. So from base of skull to the base of neck plus thorax. And one thing to know is that sometimes thoracic slices from CTs, PET scanner, PET CT, are sometimes inadequate because of long acquisition times and sometimes motion artifacts. So imaging is not only images. You have to know the clinical history and the context. So you won't suggest the same thing depending of age. In children's, it's most likely to see embryonal abdominosarcoma. In teenagers, it's more likely, more frequent to see Ewing sarcoma. And after 50, you will find mostly chondrosarcoma, liposarcoma, and some other. So age is a parameter to take into account. Another is clinical history. In case of neurofibromatosis type 1, MPNST is more common, malignant peripheral nerve sheath tumor. In case of HEV infections, leiomyosarcoma and Kaposi sarcoma are more frequent. And after prior radiation therapy, it's possible to detect leiomyosarcoma, angiosarcoma, undifferentiated sarcoma, osteosarcoma, and fibrosarcoma. As you know, some pre-existing lesions are at risk to turn into a sarcoma. In case of fibrous dysplasia, Paget's disease, ossific fibrome, you can find osteosarcoma. And in case of fibrous dysplasia, enchondroma and osteochondroma, you can find later a chondrosarcoma. So after the imaging workup, the first situation is identify tumors that are not sarcomas. So some of them are typically benign, and in this situation, you can reassure the patient, but some are malignant. So we don't have time to develop this list. The second situation is that you can recognize features suggestive of a sarcoma. These features are fatty components, myxoid components, osseous or cartilaginous matrix, cutaneous location, peripheral nerve course, tumor in mesenchymal territory, in example, the back of the neck, and a spatial aggressiveness, a huge tumor with necrosis and large osteolysis. In this example, here, you have a mass with calcification with typical appearance in rings and arcs, typical from a chondroid matrix. It's a chondrosarcoma of the larynx. In this mass, you have a typical lobulated and high intensity on T2 images, typical from chondroid matrix. It's a chondrosarcoma. In this case, you have a typical osteoid matrix calcified in the soft tissue in the pterygoid areas. So it's an osteosarcoma. Here, a deep skin mass corresponding to a dermatofibrosarcoma. In this case, in the oropharyngeal lateral wall, you have an heterogeneous mass with a fatty component typical of liposarcoma. In this case, the mass is located in the back of the neck. There are no mucosa, no lymph node, no vessels in this region, so it's more likely to find a sarcoma in this area. In this case, there is a huge necrotic heterogeneous mass of the skull base with osteolysis. It's a spindle cell sarcoma. In this case, we are 25 years after treatment of the squamous cell carcinoma, including radiation therapy. And you can see a mass with a bone osteoid production of compact bone. It's an aspect of osteosarcoma after radiation therapy. So what are the key imaging findings to report? you have to describe some important element to maximize the local control after surgery with free margins. So you have to describe muscle infiltrations, vascular encasements, like in this case, the vertebral artery encasement. Here, the internal carotid artery encasement. The bone involvement, like in the sphenoid here. Intracranial involvement and invasion of the spinal canal, here in the foramen. And perineural spread, even if it's very rare in sarcomas. So as for any of head and neck tumors, you have to make a special focus on critical anatomical interfaces, especially in the skull base. In the skull base, the first question, in case of a mass, is the bone involved, yes or not? So you can respond, no, the bone is not involved. Is the meninge normal, yes or not? You can, with MR, respond to this question, no in this case. Here you have a contact with the meninge, but the meninge is not crossed. Here, in this case, the meninge is crossed, so there are concerns about the cortical involvement. You have to determine it on the coronal MR images if this intracranial invasion is involve the cortex. In this case, the cortex is completely normal in signal and thickness. In this case, the cortex is thinned and involved, clearly. As critical is the interface to analyze in case of suspicion of orbital involvement. So when the mass is near the orbit, the first question is the bone involved, yes or not? Here you can see a little area of dehiscence, but the periosteum is not crossed. In this case, the periosteum is displaced, but there is a smooth, regular margin, so it's not crossed. In this case, the periosteum is crossed, and the mass is involved in the fat, extracranial fat. And the ultimate step is this case with a full orbital content involvement. So, should the radiologist suggest a diagnosis of a sarcoma before biopsy? If relevant, it can be useful for the selection of the biopsy sites. You can target representative area. That's in particular avoid over-differentiated and necrotic areas. To focus on enhancement area, focus on ground glass, nodule within adipose tissue, can be helpful. It can be helpful for pathologists too, because it can support pathological analysis for the choice of specimen preparations, analysis of specific biomarkers if you provide fresh tissue. It can pathologists can verify the radiological pathological correlation, can be useful to confirm the hypothesis of the pathologist. And the pathologist can ask for a remote expert pathology consultation in these rare and difficult cases. So after the imaging workup, we need a multidisciplinary team review. Donc before biopsy and after biopsy. Before biopsy, the MDT review could validate biopsy indications, the approach routes, and the modalities, US-guided, CT-guided, and if very difficult or inaccessible with imaging, endoscopic or surgical biopsy. After biopsy, MDT review will choose the best care pathway. So a few words about post-treatment imaging. it must always be comparative with baseline and post-treatment reference. It should include contrast enhancement MR and contrast enhanced CT. Given that CT MRI does not replace CT in those post-therapeutic conditions with difficult images to analyze. We need to see the bones, we need to see the cartilage, and the MRI is not as performant as CT for the bone structure and cartilage. Ideally, the post-treatment imaging should be performed at an expert center. So, in conclusion, any suspected head and neck sarcoma must have an imaging at a specialized center or a second opinion after imaging. The multidisciplinarity team review must be organized before biopsy and before onset of therapies in specialist care center. I thank you for your attention, and I'm ready for your question.
Thank you very much, Philippe, for this very comprehensive presentation and very complete. And I am not sure that we have no question until now, but maybe at the end of the webinar, we are actually more 70 people looking to the webinar, and because the time is running, we can take the time, but the time is running. I think that Wahib Ghanem from Institut Curie in Paris could present us the principle of resection of head and neck sarcoma. Thank you very much for your participation and your disponibility, and you can go for your presentation, Wahib.
Thank you for joining us. Do you see my presentation?
Yes.
Okay. Perfect. Hello, everyone, and thank you for joining us today. First of all, I would like to express my sincere gratitude to the ESSO and to Professor Dolivet for the kind invitation and for the excellent organization of this webinar. I'm Wahib Ghanem, and I'm head and neck surgeon at the Institut Curie in Paris. I will talk about the principle of head and neck surgery in sarcoma, head and neck sarcoma, sorry. I have no conflict of interest to declare. As you know, head and neck sarcoma are rare and remain a surgical challenge. I won't go into the epidemiology today, as Dr. Fernandez has already covered this in the previous session. What's important to remember is that we're not dealing with a single disease, but a diverse disease of over 50 histological types and subtypes. The prognostic factors in head and neck sarcoma include the tumor factors, such as histological subtypes, grade, and size. The anatomic factors, such as the tumor site and the proximity to vital structures. The patient factors like the age, comorbidity, etc. And surgical factors for the resection margins. Our priority is to be R0 or having clear margins. R1 when we have microscopic invaded margins, R2 when we have macroscopic invaded margin. This is not our goal. The challenges in head and neck, the anatomical density. We operate in a very expensive neighborhood, and functionally every millimeter we can affect patients' ability to breathe, speak, or to eat. And finally, we must remember that the face is the patient's identity, and it's the primary site of human recognition. So we need to keep in mind the psychological impact of aesthetic identity, and our challenge remains to be oncologically ruthless while being reconstructively meticulous to preserve the human being behind the pathology that we are treating. The multidisciplinary team board is very important. because the management, it's highly individualized, and a multimodal approach integrating surgery, radiation, or systematic therapy is often required. We insist about that because with sarcoma, the primary treatment is our best chance to cure. If we missed the first window, the opportunity and the survival chances drop significantly. And of course, having our radiologist, radiotherapist, oncologist, surgeon in the room help making a global better decision. So surgery is the engine, but the multidisciplinary team is the navigator that we need to trust and to work with. Radiotherapy, preoperative or postoperative, it's an endless debate. While preoperative radiation is common in limb sarcoma, in head and neck, we generally prefer postoperative radiotherapy. Why? Because of anatomical density of the region. So radiating the area before surgery increases the risk of wound infection, dehiscence, of carotid exposure, and even nerve injuries. So we must discuss every case to decide whether we need to do radiotherapy before or after surgery. The R0 or nothing philosophy. The primary goal is R0 resection or microscopic free margin resection. When we commit to surgery, we must be confident in our ability to achieve clear margins. We must avoid fragmented resection at all costs. If we determine that an R0 resection is not feasible and is not guaranteed, we should discuss alternative treatment such as neoadjuvant therapy or even a definitive non-surgical treatment. The diagnosis procedure, the biopsy is the first act of treatment. We strongly recommend a core needle biopsy under ultrasound or CT scan. Why? Because it gives our pathologist enough tissue to study the tumor without contaminating the surrounding area. We should avoid incisional or surgical biopsy. Remember that the biopsy tract is part of the tumor and need to be resected, so it should be as small and as direct as possible. And we must strictly avoid excisional biopsy for unknown mass. We call it frequently a hoop surgery, but for the patient, it's a catastrophe. A hoop surgery often changes the surgery from a simple resection to a massive destruction after it. So always remember biopsy first and cut second. Defining surgical margin to answer the question of our colleague. I have no answer. It depends on the tumor. While 1 to 2 centimeter surgical margin is the standard in the trunk, in the face, sometimes even 5 millimeter is often a luxury. It's difficult to obtain wide margins near noble organs such as the eye, the skull base, or the carotid artery. However, it has been shown that even small margins can provide good local control as long as the resection is R0 and not fragmented. So the reality is close but clear. Even if, surely, if we can do 1-2 centimeter margins, it's okay. It's better. It depends also on the tumor, because if we have angiosarcoma, we need to be very extensive in the resection. If you have dermatofibrosarcoma, we need to have 2 centimeters. Otherwise, or unless we have MOS study in live or even slow MOS, but we need to pay attention. So there's no answer of the clinical margin. It depends really on the anatomical side and on the histological subtypes of the tumor. Function and radicality. Our priority 1 is the radicality, meaning a complete en-bloc removal with negative margin. This is our first priority. Then the second priority is the function. We need to preserve or reconstruct the airway, the speech, or the swallowing. Sorry. The third priority is the aesthetic rehabilitation to preserve the patient's social identity. Managing the neck. No systematic neck dissection is recommended. It depends on the histological type and the presence of clinical positive or suspicious lymph nodes. So all cases should be reviewed by our radiologist and by the multidisciplinary team and discussed with the patient, who must be informed of the risk. Let's see some clinical cases. The first one, it's about an intraorbital liposarcoma. I must warn the audience that the following slides contain some sensible intraoperative images, like my colleagues. So this is the first one about the orbital liposarcoma. And this is the resection. The slide shows a radical resection, including the eye and all the orbital content. Note that the orbital rim here, I don't know if you see my mouse, but the orbital rim here was removed on en bloc without even visualizing the tumor. This aggressive approach is essential to have an R0 status. This is the eye, the orbital content with the bone here, and this is the orbital rim that was cut here. And we reconstructed the area with a foramen-free flap fashioned into a cone shape. This is a technique we've already published regarding its use in orbital exenteration for other histological subtypes. Professor Sophie Deneuve will talk more in details about reconstruction. The second clinical case is about undifferentiated pleomorphic cervical sarcoma. And this was an en bloc resection of the pleomorphic sarcoma. Here we see the carotid artery, the brachial plexus, and the trapezius muscle in the depths of the wound. To ensure R0 resection, all surrounding tissue was resected, including the jugular vein, the squamous, the SCM muscle, and the spinal accessory nerve, and the skin also. And this is an en bloc resection of the tumor. The third clinical case about a young 34-year-old man with recurrent dermatofibrosarcoma. This is a photo in the follow-up consultation. He had previous multiple surgeries, including flaps and skin grafts. And here's the CT scan and MRI demonstrating the recurrent tumor between both clavicles and invading the left one. And the MRI showing the same thing. The management plan was extensive surgical resection, including cervical resection and manubriectomy, followed by reconstruction with a manubrial prothesis and a free anterolateral thigh flap. This decision was made during a multidisciplinary team, planning a combined approach with a thoracic surgeon. This is an intraoperatively photo showing the clavicles and both first and second ribs. They were identified, exposed, and isolated to be cut after on monoblock with the tumor on block. This is after the resection. The tumor was resected en bloc with the medial halves of the clavicles and the first two ribs. We see here the surgical field. The trachea is visible in the midline with bilateral internal jugular veins and the carotid arteries and the subclavian veins with the brachiocephalic trunk and the clavicle segments and cost and the pleura here. We see it in the depth of the wound. And we see here the internal mammary artery is identified and clamped using a TKM1 clamp to use after for the reconstruction. And this is the photo of the reconstruction using a manubrial prothesis covered with the anterolateral thigh flap, and the results 3 months after that. Just a small word about the specialist center. The data is clear. Being treated in an expert center is just not. It's not just a preference. It's a survival factor. Studies have shown that survival rates are significantly higher when the management is centralized. So as a conclusion, the surgical gold standard remains a wide en bloc R0 resection and avoid the fragmentation at all costs. The importance of multidisciplinary teams and centralized management. Thank you for your attention.
Thank you so much, Waheb. Beautiful presentation, very interesting. And we have 2 questions. I have a question from the audience about the indication of preoperative radiotherapy. What are the indications of preoperative radiotherapy? Can you...
It depends on the tumor histology. But sometimes when we decide that an invasive radical resection is needed in visceral or in lump sarcoma, they do radiation to control the tumor and then doing the resection, because they consider being R1 or the risk of being R1 when irradiating the tumor is less important than we have not done the radiation before. And the local control of the sarcoma, they consider it better when the radiotherapy is before. But it's really controversial point. It's an endless discussion. And we have this discussion in every RCP, in every disciplinary team meeting. It's an endless discussion every time.
Okay, thank you very much. Just a comment more than the question. You showed that a clavicular resection is possible and sternal resection is possible. It's at the limit of head and neck, but
exactly. But that's why we did a double team with a thoracic surgeon.
Yes,
we didn't do it together, and it's the example to show that working together is essential, and we need to call colleagues when we're in the limits.
Perfect.
Even if we know how to cut a clavicle, but it's always better to call colleagues to have a backup.
Mm-hmm. Yes, sure. And that's perfect transition to Professor Sophie Deneuve presentation. You talked about resection, and now we are going to see how to reconstruct head and neck after head and neck sarcoma resection. Sophie, please. Thank you.
Thank you, Gilles. Thank you, Wahib. Can you hear and see everything okay? Yes?
Yes, it is.
Yes. So, well, good afternoon to you, everyone, and thank you for this invitation. My name is Sophie Deneuve, and I'm a head and neck surgeon at Rouen University Hospital, France. And today I would like to share some thoughts on the specific challenges of reconstructing head and neck sarcomas. So what makes reconstruction in head and neck sarcoma particularly challenging is that these tumors often affect relatively young patients with very high expectation in terms of both appearance and quality of life. These are also emotionally demanding cases for the teams because the resection can be extremely extensive and sometimes truly mutilating, as we have seen. And this is further complicated by the fact that adjuvant treatments are frequently part of the management. So we are not only dealing with large and complex defects, but also with tissues that have been exposed to chemotherapy with all the consequences this can have on healing and vascular quality. And radiotherapy is very often needed. Besides, as previously said, in the head and neck region, the reconstruction is never just about coverage. It's about restoring key functions like breathing, swallowing, and speech articulation, while at the same time aiming for the best possible cosmetic outcome. So the reconstructive strategy is really a major part of the global treatment plan and not simply the final step after the resection. So what is to be reconstructed and when? When you discuss reconstruction in head and neck sarcoma, you have two main questions. And the first is what has been resected and what does require reconstruction? Because the answer will not be the same if you're dealing with bone, like here, this huge sarcoma of the mandible, if you need soft tissues, if you need nerves, if you need digestive tract, or even sometimes in selected cases, like here, major vessels, like this example of carotid intimal sarcoma. But beyond anatomy, what really matters here is the functional interaction between all the structure. Because if you reconstruct the tongue, you are trying to preserve the articulation and the swallowing. If you reconstruct the mandible, you are restoring not only mastication, but also airway support and facial contour. And if the pharyngo-laryngeal complex is involved, then you are dealing with the separation of the food and the air and with the voice production. But actually, none of this structure can be considered in isolation because the tongue needs a stable mandibular support to function properly, and the pharynx need a functional tongue to generate coordinated swallowing. And finally, the larynx itself, it is suspended through the hyoid bone to the mandible. So if one element is missing, the other are forced to adapt. And actually, they do adapt, but often in a very suboptimal way. So that leads to the second question: when should be the reconstruction done? Because in sarcoma surgery outside the head and neck, delayed or two-stage reconstruction is often preferred because it allows time to obtain the final pathology and to confirm margin status before committing to definitive reconstruction. But here in our head and neck area, that approach is often very difficult to apply, as function cannot wait, actually. So breathing, swallowing, and speech cannot wait. So if the reconstruction is delayed, the remaining structure will begin to compensate and to develop new functional habits. And these compensatory patterns may later compromise the final results if you finally perform a delayed reconstruction. So usually in head and neck sarcoma, reconstruction is not simply just filling a defect. It is about preserving or restoring a dynamic functional unit. And for this reason, we really need to integrate the reconstructive surgery into the initial oncologic strategy from the very, very beginning. And if you now focus on the pediatric sarcomas, you will add further layer of complexity, because this is the population in which sarcomas make up the majority of solid head and neck tumors, and where reconstruction must be planned not only for now and today, but also for the growth and the development over the time. Advanced in skull-base surgery and microsurgery have made surgical resection increasingly feasible in selected cases. And again, the reconstruction has become a central part of the management. It is important to notice that for mandibular reconstruction, one important consideration is age and growth potential. Especially in some situations, bone reconstruction is more readily considered after the age of around 8 or so years, because we know that if the free flap is performed too early, the reconstructed bone will not be able to grow adequately as quickly as a child grows. So the scapulodorsal system can be particularly interesting here because it allows bone reconstruction for the jaw or the skull base, while also providing a lot of soft tissue like the latissimus dorsi component. And if you do not need the bones because the child is too small, the muscle in place can sometimes help to identify the anatomical planes more easily when you will perform the secondary surgery at the end of the growth. Finally, about the growth, another advantage of the scapular flap is that the harvest of this flap may include a growth cartilage, providing some residual growth potential, even if, of course, this potential is often reduced by subsequent radiotherapy. But by contrast, the fibular flap does not provide the same intrinsic growth potential. Besides, reconstruction must also remain compatible with all the oncologic roadmap, and especially with adjuvant therapy, with a big warning about proton therapy. As you know, in sarcoma, proton therapy is particularly attractive because of its own ballistic property and its ability to better spare the surrounding normal tissue. And this is especially relevant here in the head and neck area, where the dose distribution is totally critical. But this also have a reconstructive implication, because you know that metallic material within or close to the treatment field may interfere with proton planning and dose delivery. So if you have a postoperative proton therapy schedule, you shouldn't put immediate dental implants on your flap. And the same kind of issue will apply to all the osteosynthesis material, which may become a challenge when bone reconstruction is required. So in this special setting, resorbable fixation system like this kind of KLS system may be of interest, as their advantage are several. There are no permanent plates to remove later. They are attractive in growing patients because they do not interfere with future development. And the most important is that they avoid leaving conventional metallic component in a field that may later require proton therapy. So again, the key message is that the reconstruction must be designed not only for the defect, but also keeping in mind the next step in the oncologic treatment. So what do we have in our reconstructive toolbox? Actually, overall, the tools are really not different from those used usually for other complex head and neck tumors. And the main option are our classical free flaps, and especially osseous free flap. This flap tolerates adjuvant radiotherapy well. They can provide very satisfactory functional and cosmetic results, including, of course, the possibility of dental rehabilitation in selected cases. Neoadjuvant treatment may make dissection a little more technically demanding, as the tissues are often more edematous and they usually appear unusually wet. Finally, sometimes the veins tend to be more fragile, but actually these problems do not appear to increase significantly the flap-related complication, but they may increase the total hospital stay. The main bony flap we usually rely on are the classical fibula, iliac crest, scapula, and sometimes radial forearm osteocutaneous flap. And each of them has its own personality, and the objective is really to choose the right flap for the right patient and, of course, the right defect. So the fibula flap remains a major workhorse for the mandibular reconstruction, as you know. Its main strength is the quality and the length of a strong cortical bone, allowing multiple osteotomies. It is particularly well suited for dental implantation and long-term functional rehabilitation. And its main limitations are mainly about the soft tissue, actually, because the skin paddles are not always as versatile as with other donor sites, especially when very complex intraoral or composite soft tissues reconstruction is needed, especially in sarcoma case. And finally, the vertical height of the fibula does not fully match the native mandible, but it's not such a big problem. Besides, you have to keep in mind that in children, one must be very careful about the donor site. And if the skeletal growth is not totally complete, harvesting the fibula may expose the child to later ankle valgus deformity and instability of the ankle. So in such cases, the stabilization of the distal fibular remnant piece to the tibia is very important to protect the ankle alignment during the growth. You have other flaps that can be used. You have the radial forearm osteocutaneous flap, which is quite reliable. And one of its main advantages is that the skin paddle is very, very thin with very little adipose tissue, and that makes it very pliable, easy to adapt, especially in confined head and neck small place. Its main limitations are well known because the bone stock is very limited. The radius is really thin and it does not allow true segmental osteotomies, and this makes dental implantation more difficult. Finally, the iliac crest flap provides excellent bone quality, and its natural curvature allows very good cosmetic results, especially for the mandibular reconstruction. The drawback of this flap is that the skin paddle is usually quite small, and above all, it has limited mobility in relation to the bone, and that reduces the flexibility when complex three-dimensional soft tissues reconstruction is needed. Finally, for children and adolescents, the donor site mobility of such a flap deserves particular attention because the iliac harvest may potentially interfere with the growth, with concern regarding the pelvic stature, the spinal imbalance, and scoliosis, and so on. So it can have a possible effect on the final stature. So the scapular flap end-to-end is personally one of my preferred options, especially for sarcomas. The main strength of this bone is it's extraordinarily versatile. Because depending on the defect you are facing to, you can harvest only the scapular tip, or if you need a larger segment of bone, you can harvest the lateral border of the scapula, and you can also add a lot of a wide variety of tissue components. You can add a latissimus dorsiflap, or you can have a rib or different skin pedal based on various perforators that are on the idea. And finally, the bone allows some green stick osteotomies to shape better the curvature of your reconstruction. So this offers a very broad reconstructive palette, and it makes it particularly useful for some of these complex composite defects. And the final advantage is that, of course, it's not limited by lower limb arteriopathy, unlike the fibula in smoking patients. So actually, the only limitation from this flap is related with the bone itself, because it is a flat bone. So the stability and the long-term integration of dental implants can be quite poor. And of course, the available bone length is limited at around 12 centimeters at most. So finally, when you have to reconstruct the soft tissues, perforator flap are really valuable here because their volume tends to remain more or less the same after the radiotherapy you will need. And you can have any options such as the anterolateral side flap, the TDAP flap, the IEP flap, or any other perforator flap, which allows us to tailor the reconstruction very precisely to the defect. Their main advantage being that they minimize the donor site mobility. So in a nutshell, again, the idea is to choose the flap that best matches the defect while preserving the function and limiting the mobility. So to end it, let's have a few words about cosmetic adjustments, because even after successful primary reconstruction, you sometimes need secondary cosmetic adjustments, and these are often part of the long-term pathway. So one useful option in this setting is fat grafting. It is a simple, repeatable, and non-invasive technique that can help correct asymmetry and soft tissue sequelae, and especially in previously irradiated area. And this also can improve the skin trophicity, and it can also soften the irradiated tissue. Of course, one concern is the theoretical risk that you can stimulate the recurrence by placing adipose tissue into an oncologic site. This concern is biologically plausible because adipocytes and adipose-derived stromal cells could interfere with the tumor environment. But so far, such a concern has mainly come from experimental model, whereas the clinical data available are really, really reassuring. And we have not demonstrated any increase in recurrence when you do fat grafting in appropriate selected patient after cancer treatment. So the message is also the question is not totally closed. Current clinical evidence is overall reassuring. And finally, about the timing, there is, of course, no universally established delay. One should say that fat grafting should be performed, of course, only after completion of all the oncologic treatment in patients with documented disease control, and usually after sufficient time has passed for the tissue have stabilized, and particularly long time after radiotherapy. So to conclude, head and neck sarcoma reconstruction is challenging because it combines extensive resection, major functional stakes, and often a need to integrate reconstruction into a broader oncologic plan. In most cases, primary reconstruction should be favored unless we are dealing with a very, very young child in whom the growth-related issues may strongly modify the strategy. The growth actually remains a central challenge in pediatric patients, both for reconstruction itself and for the donor side consequence. And I would also like to remember that titanium and proton therapy may be difficult to combine, which has implications for placing implants and for all fixation systems that you are going to have to choose. So thank you, everyone, for listening, and I'll be there if you have any question.
Thank you very much, Sophie. And you're right. I have a question of a participant. Do you think what is the maximal delay between free flap reconstruction and radiotherapy?
I'm sorry. Before I don't.
After
maximal delay.
After free flap reconstruction, is there a delay for radiotherapy that you have to respect or not?
You mean the shortest delay, not the longest, I suppose? Okay.
Oh, the longer is interesting as well.
I think the longest is whenever you want. But yeah, probably it's like every time when you are reconstructing head and neck, you really have to be sure that the healing is properly done, especially there is no leaking of saliva in your neck, because radiotherapy will not improve the healing. So more or less, you cannot really plan radiotherapy sooner than, I suppose 3 weeks after the surgery, but usually it's okay. Sometimes I have a few discussions with the oncologists because they wanted to start chemotherapy very early after surgery. This is not easier, actually. But you have to wait until the healing is almost done. If there is a leak of saliva, it will be worse after any oncologic treatment. So I think the most important is that the healing seems to be quite finished.
Okay, thank you. And I have another sorry, you wanted to add something? No, I have another question. It's not easy to answer. I think the possibility of surgery in parameningeal rhabdomyosarcoma is maybe a question for Haib. And do you practice meningeal resection, in fact, or do you prefer radiotherapy in those cases? It's an open question for all of us.
Yeah, actually, I've just answered in the chat, and I said it depends on the tumor initial size and localization, and it depends on the response to chemotherapy. Sometimes we discuss the cases, and they ask to remove a relicate remaining disease after chemotherapy, and it could be possible. However, in most cases, the treatment continues with radiation.
Perfect. Thank you very much. So we took 90 minutes, more than 60, but it was very interesting, in my opinion, discussion and presentation. And it confirmed the ideas that I had, that when you don't understand a subject, organize a webinar. It's for me. And the take-home message is the same for all of us. I think that you need specialized doctors, specialized centers, and you have to favorize clinical research. And we can see today that we have progress in all specialties, and it has to be known, and that's why we are talking tonight. And I hope that we had more than 60 of 70 participants to the webinar, and you can see this webinar next week on the ESSO site. So thank you very much to all of you. If you have any comments to do, it's the moment, and if no, it's thank you and good evening. Okay?
Thank you so much.
Thank you so much.
Thank
Thank you
you.
very much.
Thank you and goodbye. Hope to see you soon.